Welcome. Give me a minute. We start. Okay. Now, welcome. In today's session, we'll be discussing about right-sided heart failure. And right-sided heart failure simply refers to the inability of the right ventricular pump to effectively pump blood from which is coming from the venous return into the lungs. Okay, so it is the inability of the right ventricle to pump the venous return to the lungs. Now, we will look at the pathogenesis, the morphology, and the clinical features of right-sided heart failure. Welcome all. My name is Waltz Muniri, and I'm the Daktari. Now, pathogenesis, the first mechanism is increased right ventricular afterload. Now, this afterload might be caused by an increase in the resistance in the pulmonary circulation. So, increased resistance in the pulmonary circulation. Now, what can cause that? It can be due to left-sided heart failure, and this is the most common cause of right-sided heart failure. Also can be due to increased pulmonary capillary wedge pressure, pulmonary artery stenosis, and acidoembolus. Now, acidoembolus refers to an embolus which has been lodged at the pulmonary bifurcation, at the pulmonary trunk bifurcation. Okay, mostly it's a thromboembolus originating from the deep venous thrombosis from the legs. Now, right-sided heart failure is usually the consequence of left-sided heart failure, since any pressure increase in the pulmonary circulation inevitably produces an increased burden on the right. Now, isolated right-sided heart failure is not frequent and typically occurs in patients with one of a variety of disorders affecting the lung. Hence, it is referred to as core pulmonale. Okay. Now, besides parenchymal lung diseases, core pulmonale may arise secondary disorders that affect the pulmonary vasculature, such as primary pulmonary hypertension, recurrent pulmonary thromboembolism, or conditions that cause pulmonary vasoconstriction, such as obstructive sleep apnea. Now, the common feature of these disorders is pulmonary hypertension. In all those disorders, the pressures in the pulmonary circulation are increased, so is the resistance. And this will result in hypertrophy and dilation of the right side of the heart. Now, in core pulmonare, myocardial hypertrophy and dilation generally are confined to the right ventricle and atrium. Now, although they are confined, there'll be a bulging of the ventricular septum to the left, and this can reduce the cardiac output by causing outflow tract obstruction. So that is one mechanism. Let's look at the second one, which is decreased right ventricular contraction. What can cause the myocardium of the right ventricle to have decreased contractility? It can be due to an ischemic heart disease. Okay, maybe there is an occlusion of the coronary artery, and so there is a myocardial infarction, hence ischemic heart disease. Also, myocarditis can be infectious or an inflammatory process. Now, another one is the non-compliance of the right ventricle. Now, non-compliance of the right ventricle refers to the inability of the right ventricle to fill during diastole. So, during diastole, the right ventricle cannot relax, and this can be due to, simply put this, the right ventricular muscle wall is stiff, so it cannot relax to allow filling. So this restriction of expansion can be due to restrictive cardiomyopathies such as amyloidosis, endomyocardial fibrosis, which is the most common form of restrictive cardiomyopathy, and low-flow endomyocarditis. Okay, so these are the three forms of restrictive cardiomyopathies. Now, the fourth and the last mechanism is increase in the right ventricular preload. We looked at the afterload, now it is the preload. Now, when you increase the right ventricular preload, this will increase the work of the pump, and sooner or later, there will be a pump failure. And this can be due to valvular regurgitation or left to right shunts, as seen in ventricular septal defects. Okay. Now, the major morphological and clinical effects of a pure right-sided heart failure differ from those of the left-sided heart failure. In that, in the right-sided heart failure, there'll be engorgement of the systemic and portovenous system, but the pulmonary congestion is minimal. Now, in the left heart failure, the pulmonary congestion will be marked, so there'll be respiratory symptoms such as the paroxysmal nocturnal dyspnea. Yeah, if the patient lies on a recumbent position, the congestion is marked and they present with breathlessness. So the patient will wake up with the feeling of suffocation. So that is in the left, but in the right, pulmonary congestion is minimal. So these respiratory symptoms will be minimal also. Now, let's look at the morphology. Now, liver and the portal system. Now, the liver is usually increased in size and weight, what is known as a congestive hepatomegaly. Now, a heart section usually display prominent passive, there'll be a chronic passive congestion of the liver. Okay. Now, a pattern which is referred to as a nutmeg liver. Now, this nutmeg liver, these are the features of a nutmeg liver. Now, the central regions, you can see this is an autopsy specimen, and this is the central areas. Now, this central area is usually depressed. Okay, one is depressed, and you can see it is depressed and red brown. Why is it depressed? Due to there will be a necrosis, centrilobular necrosis, hence cell loss, and but the periphery, you can see the periphery is okay. It is non-congested. So there'll be a congested centrilobular areas surrounded by a peripheral paler, non-congested parenchyma. Now, in left-sided heart failure is also present. Severe central hypoxia produces centrilobular necrosis in addition to the sinusoidal congestion. And this sinusoidal congestion eventually leads to the pulmonary, rather portal vein hypertension. Now, with long study in severe right-sided heart failure, the central areas usually become fibrotic. Okay, and this now causes what is known as cardiac cirrhosis. Now, maybe go back to that, not to discuss about this. Now, this is a microscopic preparation, and this can see here, this is the central venue. You can see here, this area, okay, this area, you can see it is not same as this area because here we have centrilobular hepatic necrosis and hemorrhage, and because there is hemorrhage, the red blood cells will be extravasated and they will be phagocytosed by the macrophages, and this the ion in them is broken down into hemosiderin, and they are forming the hemosiderin-laden macrophages. Now, portal vein hypertension. Now, right-sided failure can also lead to elevated pressure in the portal vein and its tributaries. Remember the tributaries of of the portal vein. The portal vein is formed by the confluence of a superior mesenteric vein with the splenic vein, and remember, the inferior mesenteric vein drains into the splenic vein. Form now the confluence of the splenic vein and the superior mesenteric vein forms the portal vein. Now, if you have congestion in the portal vein, there will also be congestion in the tributaries now. And this will produce vascular congestion, producing a tense enlarged spleen, congestive splenomegaly. Now, in severe chronic passive congestion and attendant edema of the bowel wall may interfere with even absorption of nutrients and medication. That is important. Now, also, portal vein hypertension leads to the opening of the portosystemic shunts, okay, and increased blood flow into the veins at the gastroesophageal junction, and this will form esophageal varices, which are the most important because they are prone to rupture and can even lead to massive or even fatal upper GI bleeding. Okay. Also, in the rectum, at the venous plexus found at the anorectal junction, there will be engorgement of those that venous plexus, forming hemorrhoids. Okay, and the periumbilical veins will be engorged of the abdominal wall, forming the caput producer. These are the periumbilical veins. You can see how well engorged they are. Okay, so this is a classic sign of portal vein hypertension. Okay, now what about in the pleura, pericardial, and peritoneal spaces? Now, systemic venous congestion due to right-sided heart failure can lead to transudates or effusions in the pleural and pericardial spaces, but usually does not cause pulmonary parenchymal edema. Okay, please note that. Now, pleural effusions are most pronounced when there is a combined right and left-sided heart failure, leading to elevated pulmonary and systemic venous pressures. Now, a combination of hepatic congestion with or without diminished albumin synthesis and portal vein hypertension usually leads to peritoneal transudates, ascites. So you can see how distended this belly is. This is ascites. And you can also see these veins, the periumbilical veins here, are also engorged. So this tells you there is both portal vein hypertension and peritoneal transudation, the ascites. Now, if uncomplicated, the effusion or the transudate is associated with the right-sided congestive heart failure. The transudate is of low protein content, okay, and lack inflammatory cells. Okay, so it is just, because there is just increase in the venous hydrostatic pressure. So there is like ultrafiltration of the non-protein content of plasma into the spaces. Now, in the subcutaneous tissue, there is edema of dependent portions of the body, especially the feet and the lower legs. So they will have dependent pitting edema of the extremities. Okay, and it is the hallmark of right-sided congestive heart failure. Now, in chronically bedridden patients, the edema is primarily pre-sacral. Now, some of the clinical features. Now, unlike the left-sided heart failure, pure right-sided heart failure typically is not associated with the respiratory symptoms, as I said. Instead, the clinical manifestations are related to the systemic and portal venous congestion and include hepatic and splenic enlargement, the hepatomegaly and splenomegaly, congestive hepatomegaly and congestive splenomegaly. There will be a dependent pitting peripheral edema, pleural effusion, and ascites. Now, venous congestion and hypoxia of the kidneys and the brain due to the right-sided heart failure can produce deficits comparable to those caused by hypoperfusion of the left-sided heart failure. Now, of note, cardiac decomposition is often marked by the appearance of a biventricular congestive heart failure, which encompasses features of both right-sided and left-sided heart failure. Now, as congestive heart failure progresses, the patient will become cyanotic and acidotic, and this is due to why are they cyanotic? Due to decreased tissue perfusion. Acidotic, there is increased congestion because now there is no waste elimination. So if it's lactic acid, the metabolic waste accumulate in the body, okay? And this is due to both diminished cardiac output and increased venous congestion. Now, I think we have come to the end of that, and thank you for your attention, and please follow for more of med content. Thank you.